and he's a member of the immunocompromised host special interest group of the Australian Society of Infectious Diseases, and is a member of the committees for TSANZ and the Organ and Tissue Authority. He has published on clinical and laboratory aspects of infection in transplant patients and donor-derived infections, and is going to present to us today on Pneumocystis jirovecii, colonisation or true infection. So welcome, Peter.
Thanks very much, Andrew, for the introduction. Thanks for inviting me to come and speak here about this tricky topic, but we'll see how we go. Yes, I work in Perth at Fiona Stanley Hospital across transplant groups, as Andrew said, and the public laboratory provider. So I was also going to talk a little bit about treatment controversies at the end as well, because I think that lends itself also to some of the focus of this meeting, which is about developing research agenda. Just as some form of introduction, Pneumocystis was around prior to the AIDS epidemic and was identified in malnourished infants and people with cancer, particularly children with acute lymphoblastic leukemia. And then obviously there was a lot of cases with the AIDS epidemic and also when transplantation was introduced. But actually these days the risk groups have changed. HIV cases, antiretroviral therapy does give you better immune recovery now, and there's people are quite good at prophylaxis. And in stem cell transplants and solid organ transplants now, there's about probably 1% of those getting pneumocystis, and that tends to occur after people have finished prophylaxis but still nevertheless remain somehow at risk. It has this life cycle of a trophozoite and then forms a pre-cyst and then a cyst, and in the cyst there's about sort of 8 trophozoites which can come out of the cyst. The trophozoites actually predominate in infection, and they cause, in the alveoli, they cause fluid and proteinaceous debris, which I guess might explain some of the characteristic ground glass imaging findings. The cyst, though, is sort of the colonising form and the transmissible form, and the cyst has 1,3-beta-D-glucan in its cell wall while the trophozoite doesn't. On the right-hand side is a microscopy of cysts. So these are about the size of Candida and round like Candida. So they're confused for Candida sometimes, but characteristically have this sort of helmet shape or sort of folded appearance. So this is discussing the modern sort of epidemiology. So this is a Japanese study. And the authors identified cases throughout Japan, actually, through ICD codes, and patients had to have several weeks of anti-pneumocystis therapy. And this is 2010 to 2016. And you can see now that HIV makes up about 10% of cases here. And you can see solid organ transplant and stem cell transplant about less than 5% of cases each. So the predominant risk factors these days are hematological malignancy, about 30%, and patients getting autoimmune disease, rheumatic disease, getting immunosuppressants, about 25-30%. And and the drug history at the very bottom of that table one, steroids and immunosuppressants are the main risk, as well as cancer therapy. And you can see that at the bottom, mortality still remains high, about 25-30%. Classically, microscopy has been the historical method for diagnosing pneumocystis, and it can be done by a variety of stains. There's sort of calcifluor, there's toluene blue, silver stains, but also immunofluorescent stains. You can see from this 2022 meta-analysis that sensitivity for microscopy is less than PCR, and that the immunofluorescent stains seem to perform a little bit better than other stains. However, so most of these studies were performed in HIV patients who have a high organism load compared to more modern epidemiology, and the gold standard in many of these cases was actually a composite clinical radiology, but also microbiological diagnosis. So there's some sort of introduction bias. The test itself leads to the gold standard diagnosis. So in a more modern setting, this is our data. If you diagnose pneumocystis by PCR, which is more sensitive, and you're including non-HIV patients predominantly who have lower organism load, then microscopy doesn't perform that well. So we used to use toluene blue before this study here, which is about methenamine silver stain. And I can't quite remember the data, but I think about a couple of hundred PCR positive cases, we had maybe 4 or 5 microscopy positives. This is about 110 cases over 3 years recently, to 2018, and 85 were negative, 9 were positive, and then the equivocal ones are ones where we can't tell Candida from Pneumocystis. So this performs quite poorly. Subsequent to this, we did use a immunofluorescent stain, but it really wasn't much better. So microscopy was more often positive in those who had a higher qPCR, or who had we sort of tested beta-D glucan as well, where that was higher, but it was still only about 20 to 25% of cases. So microscopy isn't sensitive enough, and it's acknowledged that PCR is overly sensitive and will pick up colonisation, so perhaps quantitation can help. In this study that we performed, colonisation was defined as patients who were either not immunosuppressed or had normal imaging, or who had very characteristic imaging for an alternative diagnosis, such as invasive mould infection or lobar pneumonia with a bacterium recovered. And uncertain were people who were immunosuppressed who didn't have characteristic imaging. So we found that the load of pneumocystis in induced sputum or in BAL with colonisation was certainly lower than the other 2 groups, with a receiver operator area under the curve of about 0.8. And at an optimum cutoff of roughly 3 logs, 1,000, a little bit less than 1,000, the sensitivity wasn't, it was 60%, so not excellent. Specificity was 92%, positive predictive value about 90%, and negative predictive value 70%. So still not perfect. We performed an analysis of other people who've done similar things, so quantitative studies for pneumocystis trying to differentiate colonisation and disease. And these are difficult because the gold standard in all of them is a little bit different. So some of them include microscopy, some of them are basically expert review of clinical manifestations or radiology, different specimen types. Some of them are bronch, some of them are induced sputum, some of them are all HIV, or some all non-HIV, some mixtures. So it's all a bit heterogeneous, but you do get the impression from the sensitivity and specificity that acute quantitative PCR performs reasonably for differentiating these 2. A crucial step forward in this regard is development of an international quantitative standard to be able to compare across assays, as has been done for CMV or EBV or BK viral load testing, for example. So BAL can be contraindicated sometimes, and induced sputum is a hassle to organise. So oral wash has been investigated for its diagnostic performance, and this is a meta-analysis, again in 2022, that collated studies. Almost all of these were HIV patients and who have a higher burden of organism, and the gold standard was often BAL microscopy. So again, quite a high level of organism to be microscopy positive. So these would tend to inflate the sensitivity of this test, of the oral wash. Studies in non-HIV patients and with a PCR gold standard are required. So at the moment, it's a bit difficult to know how to use oral wash in management. You don't have to read all this, I'll summarise it for you, but basically beta-D glucan is found in the cell wall, as we said, of cysts of pneumocystis, as well as was spoken about earlier, in Candida and Aspergillus. And this meta-analysis collected 14 studies. So these were a mixture of things. The diagnosis of a gold standard was made by microscopy sometimes PCR. Some of the studies had BAL, or some were sputum, and some were HIV and some were non-HIV. The majority, there's 4 different beta-D glucan tests. One of them's made in America. I think the other 3 are all made in Japan. And the majority test used was the American one made by associates of Cape Cod, called the Fungitel assay. And the cutoffs used were those that we used for Candida. For that particular test, it's 80 picograms per mil. So actually, you can see here at the middle of this, the pooled sensitivity was pretty good. It was, well, very good. It was sort of 95%. Pooled specificity pretty high, 85% as well. So the negative predictive value is quite high. These tests aren't registered in Australia by the TGA, and So they wouldn't be NATA accredited, and a lab would have to do a formal validation of these tests, and I'm not aware that any Australian labs are utilising them. We had a little look at the Fungitel assay, and we performed this audit on the same group of patients I showed you with the quantitative PCR. We tested serum, where serum had been stored within about 7 days of the sputum or BAL. We tested that with the Fungitel assay. So like others, we found pretty good differentiation for disease and colonisation. You can see it in the box and whiskers plot. So at about roughly 80, it's a bit less than 10 to the 2 there, which is the cutoff for Candida. So, but even at that, actually, our performance wasn't quite as good. Sensitivity was 70%, specificity 85%. Further, we looked at, whether beta-D-glucan correlates at all with quantitative PCR on the right-hand side. So definite cases are the orange squares, and the colonisation of the blue circles, and the filled-in circles are indeterminates. And so there wasn't particularly strong correlation, and we did include some HIV patients who had very high qPCR levels, so that performance might not have even been quite as good with those excluded. The French have done something similar here. It's exactly the same plot, really, with beta-D-glucan on the y-axis and PCR on the left. So in this study, they had 46 patients that either had positive microscopy or PCR from BAL, and they defined by gold standard of expert review. Basically, clinicians looked at the cases, the imaging, their response to treatment, various things, and they assigned them into disease, which are the squares, the white and black squares, and colonisation, which are the triangles. So they found, above, at PCR above 2 by 10 to the 4, they had not 100% specificity, and over roughly 10 to the 3, they had 100% sensitivity. So it was sort of this grey zone. Actually, beta-D-glucan at 100, which is with the horizontal line there, performed very well on its own. But they obviously found that it contributed with the grey zone interpretation to put people into the correct category. So one of the shortcomings of this, though, is that it is the disease category skewed with HIV patients and microscopy patients, and also the idea of a physician expert gold standard. So these are the 2020 invasive fungal disease updated guidelines, and for the first time, actually, they've got a pneumocystis definition. And as you can see from the radiology there, it's pretty non-specific. It doesn't just include bilateral ground glass infiltrates. And that sort of takes into account our incomplete understanding of the way that pneumocystis behaves. They have got a positive PCR or beta-D-glucan test required for diagnosis, and this accounts to some degree for the insensitivity of microscopy. And based on this, basically, pneumocystis is going to be diagnosed more inclusively as time goes on in studies. And I sort of bring you back to our local audit, where we had these definite cases with ground glass infiltrates, indeterminate cases where all these kinds of other infiltrates in immunosuppressed people. So the combination of those two in our study would have been diagnosed as pneumocystis. And actually, you might have noticed from that slide that I showed you that the fungal loads and the response to the percent that were treated, the mortality rates are actually very similar in the uncertain and the definite cases in our small study. So, ground glass infiltrates on the left here, and on the right-hand side, these small cysts. These won't be pneumocystis will be diagnosed by more than this going forward. So, with sort of thinking about research angles in mind, how would you design a diagnosis trial? So I think you would have to have some inclusion of immunocompromised patients who have pneumonia, perhaps certain type of pneumonia. You'd use an international gold standard diagnosis, the one that was I showed you in the updated guidelines. And I think what you'd ideally do is you would actually get oral wash, you get sputum and BAL, if you could get that, in all possible patients at the same time, and I test in one or a couple of labs with quantitative standard. Eventually, that would ideally be international standard. And it would be nice to see what happens with treatment responses at intervals with those specimens. And also you get beta-D-glucan in all of them, and again, look at intervals, retesting intervals for trend. And I think you'd be after performance in different subgroups. So I think the question to try to answer is BAL required these days if you've got sensitive PCR or sensitive beta-D-glucan? Can you actually do only beta-D-glucan, which is obviously only needs serum, much more available to obtain from patients? And is there different performance for different risk groups? These are the sort of questions that could be answered and asked. So moving on to some treatment controversies. So a lot of the active agents against pneumocystis work at folate synthesis, but also there's some we're working at sort of energy production in the electron transport chain, like atovaquone and primaquine. Beta-D-glucan echinocandins working at beta-D-glucan in the cis form, and some that we don't really know how they work. This is authors did a sort of a meta-analysis in 2021, I think it was, in the Open Forum Infectious Diseases. And so on the left, the traditional treatment of 15 to 20 milligrams a kilo of the trimethoprim component of cotrimoxazole for 21 days, they make the point that's based on pretty poor evidence. So the actual dosing on the left-hand side is based on a study of 20 children and observational data that lower dosing, but actually suggested lower dosing may be effective as well. And on the right-hand side, I don't need to read it all necessarily, but the duration was based on more or less an observational study that in HIV patients in 1984 that they had prolonged symptoms compared to those that didn't have HIV. So their point is this is not very strong evidence. And they looked at all the randomised trials that had been done for comparators and meta-analysed them. The trials were all very old. They were in HIV patients who were predominantly men, and 1986 to 1998. And obviously, since their point is that since then, you've got patients that are at different risk now who've got more risk, more chance of adverse events. They've got renal impairment, cytopenias, they're older, co-medications. So maybe the recommended dose and duration is not fit for them. I mean, you can see that a number of the alternatives to cotrimoxazole have similar sort of outcomes, particularly clindamycin, primaquine, and intravenous pentamidine, but that's not easy to use. I'll talk about atovaquone in a second. This is adverse events from these, and most of them do better than cotrimoxazole, as you might expect, particularly atovaquone and clindamycin, primaquine. So these same authors, they looked at studies where compared outcomes and adverse events from standard high-dose cotrimoxazole with a lower dose, which was either under 15 milligrams a kilo or some of them were under 10 milligrams a kilo of cotrimoxazole a day. They actually only found these 3 Japanese studies. So these were done recently, recent cohorts. They were non-HIV patients. And, in the top here, you can see mortality didn't seem to be worse with these lower dose cotrimoxazole arms. These are retrospective studies, though. And in the bottom, there was 18% less absolute risk of adverse events. So they point out that that the standard dosing is based on pretty limited data, and their view is that there's equipoise to conduct randomised trials. This is an old study, but it's the study of atovaquone versus cotrimoxazole, and worth looking at. So this was published in 1993, and was patients diagnosed histologically. So that's quite a high burden of infection. On the left-hand side at the top row, the lack of efficacy was defined really by progression to ventilation, progression of a worse gas exchange or symptoms or radiology at 7 days, or lack of improvement of those things at 10 days. So you can see atovaquone efficacy was inferior in that regard, as was survival in the 5th row. And we'll delve into that a little bit in a minute. On the right-hand side, you can see that adverse events were much more frequent in the cotrimoxazole group, and most of them were at least grade 3 adverse events. So some of the details important. So there were no deaths in the mild group in either arm, and that was defined as an AA gradient under 35 millimetres of mercury. There were 11 deaths in the atovaquone group, and actually, so 4 of them were due to pneumocystis, and 2 of those patients had only had 1 day of atovaquone. The other 7 deaths were actually, a lot of them were due to bacteria that cotrimoxazole can have some effect against, so pneumococcus, Staph aureus, Klebsiella. They also, on the right-hand side, looked at atovaquone levels, and there was an association in that middle column of increasing level with increasing success. There was also association with level with an outcome with diarrhea. They used tablets in this trial, and more recently, the suspension that we use now has about 2-fold the exposure of the tablets. So I guess in conclusion, atovaquone suspension's a reasonable choice for people with mild disease who are expected to absorb, particularly those that might have prone to adverse events from cotrimoxazole. Okay, so this pretty much summarises what we know about echinocandins, which is that they appear to have activity in observational reports and in some animal models. So there's been interest in using them. The idea has been, because they work on the cis form and not trophozoite, that they probably need to be used as an adjunct rather than alone. And there's some randomised trials in that regard in critically ill non-HIV patients ongoing. And they make the point that resofungins once a week, and that might be something that's kind of handy for pneumocystis as well. Azithromycin, there aren't many reports of azithromycin used for treatment of pneumocystis. I had a look, I couldn't find many at all. It has been effective at preventing pneumocystis in animal models, but it seemed to need to be used with a sulfonamide for best activity. So these are results that are actually a secondary outcome of a MAC prophylaxis trial in AIDS patients. So these were patients who had CD4 count less than 100, most of them less than 50, and are randomised to weekly azithromycin, 1,200 milligrams, weekly azithromycin with daily rifabutin or only rifabutin, about 700 patients in the trial. 97% of them were on standard pneumocystis prophylaxis, and of which 60% were cotrimoxazole, 20% dapsone, and some were others, pentamidine. So even though these patients are getting prophylaxis, actually pneumocystis was diagnosed in about 10% of them, 78 patients. Half of the diagnoses were clinical only, and then half of them were microscopy. And they noted that patients who were in the azithromycin arms had an incidence of pneumocystis of about half compared to those that had only rifabutin. And this risk reduction was even greater where we're looking at microscopy positives, and also greater where people weren't on sulfonamides like Bactrim and dapsone. So uncertain, but it seems to have some effect at preventing anyway. So if you were to do a treatment trial design, so I think it would make sense to include patients with the gold standard international diagnosis of pneumocystis. Actually, it occurs to me that adaptive trial would be the most, perhaps the tidiest way of doing it. When you'd have a standard dose of cotrimoxazole for 21 days as your control arm, you'd look at a lower dose of cotrimoxazole. You could even look at 5 milligrams a kilo a day. It's like 1 BD of Bactrim for mild disease. And you might investigate different primaquine doses. I'm aware that increased doses of primaquine are being investigated for malaria and seem to be reasonably tolerated. Look, it would be nice to have an arm that had very little interaction and toxicity, something like echinocandin, azithromycin, atovaquone. That would be something that would be quite free of adverse effects probably. And you would look at 21 days versus either 14 or maybe even 10 days. And by outcomes, mortality occurs, enough, 25 to 30%, which is unfortunate, but could be used as an outcome, but also, clinical improvement, parameters that have been used in other trials. And, you take the opportunity to look at some bio sort of kinetics and obviously adverse events. Just one slide on prophylaxis, which we won't cover really at all, but there is a lot of unanswered questions about pneumocystis prophylaxis. And so while it's established for stem cell and solid organ transplant recipients and certain haematology patients, for autoimmune diseases, less data and pretty heterogeneous practice. And as you see, these are patients that are breaking through, getting infection and with a significant mortality risk. So there's some questions listed here, who needs prophylaxis? Are there those who are at risk, but might be at risk because of age or underlying lung disease or environmental exposure factors? Can we use total lymphocyte count, which is commonly measured, or CD4 count to guide risk or discontinuation, for example, after cyclophosphamide, alemtuzumab, ATG, those kinds of things? The dosing of cotrimoxazole is sort of all over the place in the trials, but and then some people have questioned the safety of cotrimoxazole with concurrent methotrexate. It doesn't seem to be an issue based on observational data, but to be investigated. And then re-challenge with allergy is something that's been looked at already to some degree. And then you could obviously look at comparative efficacy or safety or cost effectiveness of alternative agents to cotrimoxazole. So, I mean, my summary of this is efficacy studies would be pretty hard because the event numbers are quite small in most of these groups. You need a pretty big study, multi-centre, long time, but actually safety and tolerability studies and cost effectiveness studies would actually be much more feasible. Okay, so, I mean, I think if we drill down to what I've said, we still don't have we've got a gold standard diagnosis for pneumocystis, but it's still not very good. HIV is different from non-HIV, and this has really hampered diagnostic studies. And most of the studies to date have been in HIV patients. I think actually a bit like aspergillosis and other things, there will sort of a composite of clinical risk, radiology, and microbiology will remain as the diagnosis. Beta-D-glucan appears to be quite an accurate test, and actually in some of these studies maybe even better than PCR, and is more easily obtainable. And I think Australian labs should invest in trying to use it. Quantitative PCR requires an international quantitative standard to be able to compare assays. Actually, the optimal respiratory specimen is still a bit uncertain. So although bronchoscopy performs better in the microscopy studies, it's not really clear if you've got a sensitive PCR, if that still holds true. And finally, traditional treatment is based on pretty low quality evidence and is often complicated these days by toxicity. And new approaches should be investigated, and maybe by adaptive trial design. Thanks.
Thanks, Peter. That was really helpful. Just before you do run up, we did start a little bit late, but we probably do have time for one or two questions if there's in the audience. Have you got an opinion in the non-HIV population about that?
Yeah, yes, I didn't touch on that, did I? There is some Burma data for HIV cohorts, which has been basically translated into non-HIV cohorts. So those with sort of significant hypoxia, it's quite common practice to give corticosteroids, but I don't think we have a lot of robust evidence to support that. And I mean, you're right, actually, I didn't include that. That would be included as one of the arms of a trial to answer that question. And, the doses that we use are quite high, and they're sort of for a reasonable period. Again, you wonder whether people really need those high doses or for that period, because you can get some complications, particularly in these sort of patients, the modern patients that are getting pneumocystis. So another question to be answered.
Adam?
Thanks, Peter. That was a brilliant talk. I loved your slide about potential sort of adaptive, platform trial. Given the non-HIV population is quite a heterogeneous sort of population, how would you go about designing such a trial with so many different types of patients?
Yeah, it's difficult. I think it would have to be driven by probably infectious diseases people, because as you say, you've got sort of rheumatoid patients, rheumatologists. I mean, in my experience, they're doing quite a lot of private practice, and they do manage patients when they get infections and things, but I don't know that it's necessarily their primary interest. I think we'd have to drive that. The haematology patients obviously were a bit more captured in the hospital rather than the outpatient setting, and there's, haematology and infectious diseases, have pretty good links. So I think, like a centre like ours, I think we probably have maybe, I'd have to look at it, but roughly 30 or 40 PCR positives a year. It's not stacks. You'd probably need and some of those are colonisation. You would need, quite a few centres. and need to be coordinated. But, you know, as we've been talking about, Australia is a place where coordination can happen, and maybe this is the sort of thing that can occur. You know, we were talking last night, you know, the ICU network has been very good around Australia at coordinating, and maybe, yeah, as you say, it's different sort of groups, so it's hard to get everyone together, but infectious diseases might be able to facilitate it.
Thanks, Peter. There are a few more questions online, but just in the interest of time, we might move on.
Okay.
So thank you again, Peter, for that wonderful presentation.